Good morning, everyone, and thank you for spending your morning with us. My name is Dr. Emil Tan, and I head the Department of Colorectal Surgery at Singapore General Hospital and the National Cancer Centre of Singapore. The department is Singapore's first and only fully specialized department of colorectal surgery, having been formed in order to serve the gastrointestinal needs of Singaporeans and its residents. Rectal cancer is our topic today. The most important aspect of this disease is prevention, particularly through active screening. Colorectal cancer is a preventable and treatable disease, and my team and I will talk to you today about some of the state-of-the-art treatments that can be offered in our institution. May I introduce our first speaker of today, Dr. Kaur Shaunan, who is an associate consultant with the Department of Colorectal Surgery. Dr. Kaur.
Okay, let me share screen. Can I share screen?
Yes, so now you can start now. Yeah.
Okay. All right, can everyone see my screen?
Yes.
Okay, thank you. Yeah, hi. So I'm Dr. Kaur Shaunan here. So today I'm going to present to you guys on this topic. There is blood in my stools. As you can see on this slides, rectal bleeding can present itself in many different forms and severity. These are the few common types that we see both in the wards as well as in our clinic. You can have patients coming to us with some blood stain in the tissue paper. You can have patients complaining of blood dripping in the toilet bowls. You can have the more severe type where patients will complain to you that they are only passing out muddy, bloody stool content. So what does it mean when you have this rectal bleeding? The most common type of, the most common causes are stools, hemorrhoids or piles. The other things are anal fissure, which is a tear in the anal region, most commonly caused by constipation, a very hard, bulky stool. The other things that you guys might be familiar about would be the diverticular disease, which we always associate this to be a disease of aging. And you can see the other things are colitis, rectal ulcer, not as common. But the most feared causes of rectal bleeding are colon cancer and rectal cancer. So when should I seek help? If you have experienced first episode of rectal bleeding, you should seek medical help to get yourself examined. Or you have experienced heavy flow with associated abdominal cramps, and we also advise that you seek immediate medical help because that is also usually associated with a significant amount of bleeding. However, if you experience any of the symptoms below that comes after the bleeding, such as rapid and shallow breathing, dizziness, blurred vision, felt fainting, confusion, you feel nausea or cold and clammy, these are signs that you have lost a very significant amount of blood, and hence you should immediately call for emergency for assistance. This is the other form of bleeding, the bleeding that you cannot see with your naked eye. In our medical term, we call it occult bleeding, okay? So the common cause of occult bleeding are disease of the right colon or other early cancer and polyps. As you can see here on the photo on the right hand on the slides, it's a stool kit, fecal immunochemical testing kit that is being distributed by Singapore Cancer Society on a regular basis. This kit will help us to detect the bleeding or blood in the stool that our naked eye cannot see. I will just take this opportunity to broadcast to you all about this available screening program that is in Singapore. And the best of all, it's free of charge. So long as you are a Singaporean or permanent resident, if you are aged 50 and above, you have not done an FIT screening in the last 12 months, and have not done a colonoscopy in the last 10 years, or otherwise advised by a doctor, you are then eligible for once per year, free of charge FIT kit screening. So please do feel free to reach out to them if you fulfill this criteria. So if you end up with a stool kit tested positive for occult blood, then this usually will be the next procedure to investigate and further evaluate for the causes of your rectal bleeding. Colonoscopy is an invasive procedure. However, it is very safe. It requires you to go through some bowel preparations, such as some fiber diet restriction. You need to drink the solution to cleanse the bowel. The procedure will be done under sedation so that you don't feel too discomfort and not too much anxiety. This procedure can be repeated once in every 5 to 10 years. And of course, the frequency will change depending on the finding as well. If you were to find large or numerous polyps, then the frequency will be shortened as per your doctor's advice. This is just a slide to show you guys the relationship of rectal bleeding and stages of cancer. It's been shown on publications that the number of days that the patient presents with rectal bleeding, the higher the number, more it is associated with a later stage of colon cancer. Hence, don't take rectal bleeding lightly, and do get screened even if you don't see rectal bleeding and if you fulfill the criteria. Thank you.
Thank you very much, Dr. Kaur, for your informative sharing. The next speaker is Dr. Sherilyn Fu, who's a senior consultant in our department. She's going to share on local excision of rectal cancers and polyps. Dr. Fu, please.
Hi, everybody. My name is Dr. Sherilyn Fu. I'm going to share my screen first. All right, I hope everyone can see the screen. And my topic today will be on local excision of rectal cancers and polyps. My colleague, Dr. Kaur, earlier explained to you how to look out for signs and symptoms of rectal tumors. So I'll just start with local excision of rectal tumors. What are rectal tumors? Rectal tumors actually means, a tumor actually means a growth, and the growth can be cancerous or non-cancerous, and non-cancerous meaning benign. They can also be small versus large. So you can see in this picture, this is actually a small polyp. It's a fairly magnified view on colonoscopy, but actually this polyp is only about 1 to 2 centimeters. Whereas on the right side, we can see a fairly large polyp. This polyp occupies about half the circumference of the large intestine on a colonoscopic view. And this is quite a big polyp. And now benign versus malignant. Benign is actually the medical term for non-cancerous polyp. On the left side, actually, this is a benign polyp. And on the right side, these are examples of a malignant cancer. A malignant cancer is where the growth is bigger and certainly much more abnormal looking. So this is a small cancer, whereas at the bottom is a large cancer that's almost blocking up the entire opening of the intestine. So how do we remove rectal tumors? Simply put, there are two methods. Either we remove the part of the rectum where the tumor is. So in this picture, we can see that if, for example, there's a cancer in the rectum, this section of the rectum is cut away, and then the healthy intestine, the colon, and the anus join back up together. So in this type of operation, we not only cut away the cancer, we also cut away the lymph nodes that are surrounding the tumor. It is suitable, of course, for large tumors and tumors that are obviously cancerous on a biopsy. and especially stage 2 cancers and above. But then you might ask, what if my cancer or my tumor is very, very small? Is there an option? Yes, of course there is. So this is what I'm going to talk about in my talk. Local excision refers to just cutting away the growth inside the rectum rather than cutting away the entire rectum. So the main difference is that lymph nodes are not removed in this surgery because we are only removing the growth. It is obviously more suitable for small tumors and not big ones. It is very suitable and is ideal for tumors that are non-cancerous or benign on the biopsy, and even for early stage 1 cancers with no high-risk features. So how do we evaluate these rectal tumors? First, as Dr. Kaur mentioned, the patients need to undergo a colonoscopy. The main purpose is to actually see the growth and to do a biopsy to check whether it's cancerous or not. And then next, we need to do certain tests called staging tests, and these frequently include an MRI scan, something like this, or an endorectal ultrasound if the growth is quite small. This allows us to see how deep the growth is and whether or not the growth is suitable for local excision. So after we've done all these tests, if the growth is benign or an early stage 1 cancer, local excision can be considered if it's technically feasible. What are the methods of local excision? There are several methods. The simplest, of course, is just during the colonoscopy, we can remove benign polyps or small polyps using things like a snare. So you can see in this picture, we're using a snare polypectomy to just remove the polyp at the time of the colonoscopy, and then this is completely removed. There are other methods that are slightly more technically challenging, such as endoscopic mucosal resection or submucosal dissection, and these are done endoscopically during colonoscopy as well. So these are methods where the tumor or the growth is lifted off with some saline injection underneath, and basically is cut away by the endoscopist. Another technique is called transanal excision. So just to orientate you, this is a picture of actually the anus that's opened up with an instrument. There's a small growth just inside the rectum that's about 1 to 2 cm, and we can obviously see this from the outside. So we can just make a cut around it and cut it away, and this is called transanal excision. But something more exciting that I'm going to talk to you about is something called transanal minimally invasive surgery. And what exactly is this? So actually, this is a laparoscopic or keyhole method of removing growth inside the rectum that are much higher up that cannot be accessed easily just via the anus. How do we do this? So what we do is we put a contraption into the anus like this, and then we put gas through this tubing into the rectum to enlarge the working space. So after that, we will put a camera inside these, what we call ports or these channels, as well as instruments, so that we can find the growth and cut away the growth with these long laparoscopic or keyhole instruments. So of course, nothing beats a picture or a video. So I will show you a demonstration of how this is done. So this patient actually has 2 cm growth inside her rectum. And in this video, I'm demonstrating how this growth can be removed with a keyhole method. So what we are seeing is actually a laparoscopic view of the growth inside the rectum with those instruments that I showed earlier. And we are using a diatomy. A diatomy basically is an instrument which allows us to burn around the growth so that we can clearly cut around the borders of the growth and remove the entire growth successfully. And all this is without any additional openings inside the patient's tummy. This is purely done through the anus. You can see that visualization is very clear. And this is after removal of the growth. We give it a good wash. There's hardly any bleeding. And we can even do stitching of the wound to close up the wound after we have removed the growth. Of course, this part and this type of surgery can be technically challenging, and only colorectal surgeons with the appropriate expertise would be able to do this type of surgery. So in this video, I'm showing you how this defect, we call it a defect, which means that this opening is closed or the wound is closed, so that at the end of the surgery, there will just be a straight horizontal line like this, and then it's almost as good as new again. So how do patients recover after such a surgery? Actually, they're discharged on post-operative day 1. So actually, this is how the wound looks like immediately after the surgery. And then 3 months later, we bring the patients back for colonoscopy. You can see that the stitches have all dropped off by then, and the wound is almost invisible. You can see some semblance of a scar, but we need to do a frequent colonoscopy to make sure that the cancer doesn't grow back. And of course, the patient also needs repeat scans to make sure that there's no spread of cancer to the lymph nodes or other organs. So we regularly would do a CT scan and an MRI to monitor this. So in summary, local excisions of rectal tumors is safe and effective in selected patients. Of course, not all rectal tumors are suitable. Small and benign or early stage 1 cancers are the most ideal. The main benefits, as you can see, are minimal detriment to bowel function and very fast recovery. Patients don't have much downtime at all. But close surveillance is required after local excision, as surrounding lymph nodes have not been removed. So of course, never take your health for granted. Please go for screening. And you may have heard that 45 is the new 50. The average, the recommended guidelines in Singapore is actually 50 years, but some of the countries have moved towards moving this screening age to even 45 years. Thank you.
Thanks very much, Dr. Fu, for your presentation. I'm going to talk to you a little bit more about rectal cancer via the abdomen. When a more radical resection is required, because the tumor is more advanced. I'm going to share my screen now. Okay. So I'm Dr. Tan, and I'm the head of the Department of Colorectal Surgery in SGH and CCS. It's my great pleasure to talk to you today again about rectal cancer and its treatment via the abdominal space. Now, some of you will recognize these old pictures. The one on the top is Joseph Lister with the carbolic acid machine, and the one at the bottom is William Morton doing the first operation under general anesthetic. Now, in the old days, many things had to be either excised locally or through very unusual methods because it was impossible to put somebody to sleep. Patient will be wriggling, and it's actually very painful to have surgery if you don't have some form of anesthetic. But the invention of asepsis through the use of the carbolic acid machine you see there and general anesthetic really changed how we do things. So historically, abdominal approaches were used really for post-mortem. So when a patient had died, people were cut open via the abdominal surface to look inside to see what was happening and what had caused the death. Because it was simply too difficult and too scary for both the surgeon and the patient to actually perform it via the abdomen. So many other ways were invented. There is a method from below, which Dr. Xiao will talk to you a little bit about again, which has made its way back into the mainstream. A posterior approach by Ernest Krasky via the back surface. And then the anterior approach, which is the one that we use most commonly. You have seen over the years, many people who are a bit older would have had that kind of incision that you see there, which is a midline incision along the abdominal space. It opens you up, eviscerates where you can see all the bowels and all the organs straight in front of you. The surgery is relatively straightforward when it's done like that. You can grasp the tissues and you have full access to all the abdominal and pelvic organs. Now, rectal cancer changed drastically over the last 30 to 40 years because rectal cancer, being in a very confined pelvic space, was generally regarded as a much more serious form of cancer. It was harder to take out. It had a much higher local recurrence. So surgical technique was very important, as well as the technology used to perform what we call the total mesorectal excision, which means removing the cancer, the surrounding tissue containing the cancer, as well as the surrounding lymph nodes and blood vessels, which are feeding the cancer. Now, traditionally, this was performed open, but over the years, could be performed by laparoscopic means, which is the minimally invasive ports, or now with robotic systems as well. So in MIS surgery, which we perform as standard of care for very major surgery nowadays, for all your radical resections, we can perform this through small little tiny incisions. We will find an extraction site, which can be through a natural orifice or through the belly button or a new hole created in your tummy. But essentially, you have a number of small incisions made on your tummy. We have an optical device and special instruments which allow us to perform everything which was done in the open fashion in the old days, but is now performed with great agility with new instruments and energy devices. In addition to the traditional laparoscopic approach, which has been around for about 20 years now, 20 to 30 years now, is the addition of a robot. So the robotic surgery has become more and more mainstream as more countries have used it. It is slightly more expensive, but gives you very fine control and is very good in a very small confined space. So what's robotic surgery? In SGH and the Da Vinci robot is used. This is the most mainstream robot in the world at the moment. The surgeon works from a computer console with the instruments mounted on robotic arms. The optics are slightly better with three-dimensional vision, but most importantly, the surgeon's hand and wrist movements can be replicated directly by the robotic arms, making the surgery far more precise. So you can see here that after the setup, generally we will have one assistant next to the robot, and the surgeon will be at the console. So this gives the surgeon enhanced visualization, better dexterity through the use of the wristed instruments, improved precision and accuracy, and the ability to operate in very deep confined spaces. Now, most of all, I know that not such an important thing sometimes, but the surgeon comfort is also increased because the surgeon is not scrubbed up and sitting comfortably at the console. For the patient, for both laparoscopic and robotic surgery, there's generally reduced post-operative pain, minimal blood loss, very small scars, and a very quick recovery. So if you think about it, in the old days when you had a large cut, people were staying 1 to 2 weeks sometimes. In SGH now, traditionally people can go home on day 1, day 2, and almost everyone goes home by day 4 or day 5. So this is the extent to which minimally invasive surgery now allows us to perform radical operations when the cancer is much more advanced. So the advantages are particularly seen in patients who are male, obese, with a narrow pelvis. Men generally have a more narrow pelvis, as you know. And when the tumor is bulky and there's less space to work in, and particularly as the lower you go, the tighter your pelvis becomes. So the advantage of the minimally invasive instruments is very good. So just as a snapshot, you can see both externally as well as internally, male and female pelvises are different. With female pelvises, you tend to have more space. With male pelvises, tends to be much tighter. And anything that can reduce physical side-to-side movement and give you increased agility in a small space is helpful. So to demonstrate some of what we do in the minimally invasive systems and what you look like on the inside when we're performing a radical surgery for a more advanced cancer, I'm going to show you a video of a gentleman, 52 years of age, with a large, bulky circumferential cancer in the rectum, and I'm going to talk you through this. So this patient had a significantly sized cancer in the lower rectum near the pelvic floor, and here we show you the operation staring into the pelvis. So the pelvis is right in front of you there, and the robotic arms are doing the work under the control of the surgeon. You can see there's very little side-to-side movement. Anything that is movement is intentional. There's no tremor. So if the surgeon were tired or if the surgeon were stressing or straining in a particular direction for long periods, you wouldn't see that translated because the robotic arms will filter that movement out. And you can see here that in order to get a good mesorectal excision, to get all the lymph nodes and clearance of the blood vessels, it's a very, very small confined space that you're working in. Now here you see the front, and this is a man. So right up there where the additional robotic arm is holding things up is the prostate, which will come into view shortly. And you can see that the white organ is the prostate, and we're pushing the prostate away. And the enhanced visualization allows us not only to see the organs themselves, but also the nerves and the very fine blood vessels around it. So one of the big fears of doing surgery like that is damage to other organs, nerves, as well as function in the future. And with minimally invasive surgery and the technology we have, we're able to do things very carefully, with great precision, and with great visualization. So the operation continues down all the way circumferentially. And in this case, the patient unfortunately had a very, very low tumor, which was right down on the pelvic floor. Now, in the old days, a tumor of this nature, even 20 years ago, would have resulted in the total loss of the rectum and with a permanent colostomy. But in this case, because of the precision of the instruments and the technology we now have, we're able to save most of these anuses and therefore perform a joint still, and the patient will get out of this surgery with very minimal side effects, with an almost normal quality of life from before. So thank you very much. Remember that screening is important, and I'd like to thank my entire team here today for their wonderful presentations, and also to stay tuned for one of our patients who will give us a personal message at the end of this talk. Thank you very much and good morning.
Hello, good morning to everybody. I'm Dr. Xiao. I'm a consultant from SGH Colorectal Surgery. Thanks to everyone who is tuning in today, and thank you to PRS from SGH for organizing this event. Now, I will share my screen. Can you see my screen, Ziyun and the rest?
Yes.
Okay. Now, we're talking about rectal cancer surgery via the anus. Now, this is just an interesting slide showing a low-cost cosplay of the real thing. It's quite apt because One Piece is now trending on Netflix. Now, what's the relevance to this talk? Now, rectal and colon surgery are not the same, even though they are called colorectal surgery, but they're very different. Now, the rectum is the last maybe 12 to 15 centimeters of the large intestine. And it is located in the pelvis, which is where the uterus, the bladder is. And this rectum does not have the same protection as the colon, an additional layer called the serosa. Therefore, when you have a growth in the rectum, it tends to spread to nearby organs in the pelvis, like the bladder, the womb, the prostate, the seminal vesicles, and also the vagina. In addition, rectal cancer can also be very close to or even involving the anus. Therefore, after surgery, you can see the difference in the chance of coming back. For colon cancer, it is about 2% overall. For rectal cancer, it can be up to 20%. Therefore, the management and surgery for rectal cancer and colon cancer is not the same. Now, just a little bit to add on to Professor Emil's talk. Now, in the early 1900s, a man called William Miles described what we call abdominal perineal excision of the rectum and the anus with a permanent stoma. I think some people ask this question on the feedback box. What this entails is that this is the colon and this is the rectum, the last 15 centimeters. If the tumor is somewhere here in the rectum, this man sort of described a surgery to remove the tissue around the rectum and the anus as well, with an end colostomy, a stoma bag, which is permanent. Now, his teachings at that time and research were groundbreaking because this enabled cure of rectal cancer when before it was very hard to treat. And this actually formed the basis of modern rectal cancer surgery. Now, of course, there have been many advances. And in the 1950s, we found that removal of the rectal tumor and joining the colon to the anus or the remnant rectum was possible, which means that the stoma was only temporary and not permanent because you still had the anus left and perhaps a little bit of residual rectum. And as time went by, next few decades, because of improvement in medical device technology and technique and training, we found that we can do surgery closer and closer to the anus without sacrificing the anus and having a permanent stoma bag. However, in the 90s, additional advancement was made, and we found that chemotherapy and radiation could shrink the tumor and make surgery easier and also reduce the recurrence rate of cancer. So very often now, rectal cancer, we may advise for chemotherapy and even radiotherapy. And in the late 2010s, we found that giving all the chemotherapy and radiation before the surgery further improve survival of patients. Now, in recent years, or rather this year only, there have been quite sensational news where we use a special medication called immunotherapy, sees the tumor completely disappearing in some patients. I'm sure some of you may have read this news. So, however, this is still very, very preliminary in terms of research. And this study only included 12 patients. But these 12 patients had no chemotherapy, no radiation or surgery. They only had this thing called immunotherapy. Now, while we are doing trials with the National Cancer Center at SGH, this therapy is now quite far from routine practice. Now, just to elaborate again on what was said previously, currently we do keyhole surgery for rectal cancer quite routinely. And there are three types: laparoscopy, the normal keyhole surgery; robotic surgery, which Dr. Emil has nicely showed some videos of; and I will talk about transanal surgery, or surgery through the anus, transanal surgery. Here you can see some differences in the old method of open surgery. The scar is very big, a lot of pain and a bit of delayed recovery. With keyhole surgery, we have some small holes, but the surgery has much faster recovery, with the patient getting discharged very early after even major surgery. Now, laparoscopic surgery, you can see here how we do it. It does require a long period of training. That's why in SGH we emphasize proctorship, mentorship over many years. Robotic surgery, you can see how it's done here. It's better ergonomics, slightly higher cost than normal rectal cancer surgery. This is the robot, the Da Vinci robot, as Professor Emil has shown earlier. Now, what is transanal surgery? Transanal surgery is an alternative to doing surgery from the top down. Top down meaning the normal keyhole surgery or robotic surgery, because the incision is from the tummy. Bottom up surgery is through the anus. So this is an alternative to top down surgery. And it has some advantages because it avoids the difficulties of top down surgery within a very narrow cavity called the pelvis. Now, this is the method we use for transanal surgery. Now, I'd like to digress a little bit to talk about the risk of leakage after rectal cancer surgery. Now, I mentioned earlier, with newer advances, we don't have to have a permanent stoma. So when we have a cancer, remove the cancer and the tissue and join the bowel together, both ends together like a pipe, right? But this joining area has a risk of leakage if healing is not so good. And how does this, what factors would increase the risk of leakage? Cancer close to the anus, like rectal cancer; previous radiation, which can be the treatment for rectal cancer; diabetes; ongoing infection; poor immunity, as well as other risk factors. Now, a stoma bag is often done upstream of the joining area to protect against this area leaking. And this is temporary because after the area has been healed, we can close the stoma bag and the patient can pass motion normally. However, we know that the stoma bag is, of course, no one likes a bag. Complications may be quite common, like skin irritation, output from the bag causing dehydration, ongoing cost of the bag, and the time taken from surgery and creation of this bag to reversal of this stoma can be several months. Now, during the transanal technique, there is a way to reduce the risk of bowel leakage. How this is done, we pull out a short segment of colon from the anus, and this is left for 1 week before joining of the colon to the anus. And this removes the need for stoma bag for patients with rectal cancer. However, I must stress that this is not suitable for all patients with rectal cancer. And for patients which this is suitable or not, this should be discussed thoroughly with the specialist who is in charge of the patient. So this, I apologize if these pictures are a bit gory for some people, but just to show that this is the platform we use for transanal surgery, and the tumor with the bowel is removed to the anus. Here you can see the tumor with the bowel cut open. And as I was saying before, this short segment of bowel is left outside the anus for 1 week before this is cut away and a normal joining is created. And here you can see the end product of the abdomen. There is no stoma and the wounds are still very small. Now, we have done some studies showing that this technique is very good and safe in SGH. Now, just a last few words on screening. And you can see here that Dr. Sherilyn was talking about having screening earlier. Now, the age of screening is still 50 in Singapore, but in the US, it has gone down to 45 because younger patients are developing polyps and cancer. And in particular, rectal cancer, you can see that the incidence has increasing 3% per year since the 1970s. And the proportion of rectal cancer under 55 has doubled from 15%, 30% in the last 2 decades. So very tellingly, this is said by one of the top surgeons in the US. We don't know what's going on, but it's increasingly clear that's happening. So more research is being done in this area. Now, does this apply to Singaporeans? So I think this is another talk which you can attend every March in SGH called the Colorectal Cancer Awareness Talk, and to describe more about screening and when to do screening. Now, in Singapore, half of patients with cancer are still diagnosed at the later stage of 3 and 4. Now, cancer is, as mentioned before by Dr. Kaur, arises from a polyp, and cancer can be prevented by colonoscopy and polyp removal. So this must be emphasized. So screening with either a FIT test, stool test, or a colonoscopy can detect early cancers as well, which can increase the chance of successful treatment. So in summary, rectal cancer treatment is much more complex than colon cancer treatment. Now, minimally invasive options like keyhole surgery, robotic surgery, or transanal surgery can improve the recovery process. But surgery must always be performed by a trained colorectal surgeon. Lastly, screening can prevent colorectal cancer. Thank you so much for your time and attention.
Thank you, Isaac, for your talk. Thanks everyone again for this. We're going to move now to patient sharing by Madam Jiang, who is a survivor of rectal cancer.
大家好，我是蒋红玲，今年44岁，是一名直肠癌幸存者。今天我要和大家分享我的经历，希望能带给那些正在遭受病痛折磨的病友一些战胜疾病的信心和鼓励。去年1月份，我感觉肛门有些痛，一开始我以为是痔疮，就去家附近的诊所看医生，吃了药之后，症状稍微有点好转，但还是痛，又加上当时有疫情的原因，直到3个月后开始有出血的时候，我又去诊所见医生，就这样我被转诊到了政府医院，专科医生让我做了结肠镜检查和扫描，诊断结果是局部晚期直肠癌，这个结果对我来说是一个巨大的打击，我感到无比的无助和恐惧。看到一些癌症病人经历的痛苦，起初我也有放弃的念头，但一想到2个孩子还有爱我的家人，我决定勇敢地面对和接受现实，于是便开始了我的抗癌之旅。医生建议我先进行化疗和放射治疗，然后再手术。经过8次化疗和25次的放射治疗，我在去年的12月份做了根治性手术， 手术采用机器人手术系统。一开始，我对机器人手术系统有一些疑虑和担忧，医疗团队便解释这类手术的过程。手术后的第4天，我就出院回家了。医生说，为了让我的肠道休息和快速的恢复，我需要带一段时间回肠造口袋生活，大概1个月的时间，我就慢慢习惯了带着造口袋的生活。虽然带着它不太方便，但也并不太会影响出行和做简单的运动。造口袋带了3个月多一点，医生就让我拿掉了造口袋，恢复了正常排便。在今年的6月份，我就又回到了我的工作岗位。在整个治疗过程中，我的先生和孩子给了我很多的关爱和鼓励。我是一名基督徒，每天祷告、读经，唱诗，寻求从主耶稣那里得到的内心的喜乐和平静，让心里的负面情绪得到了释放。还有教会一些姐妹的陪伴、安慰和鼓励，这些都是使我能够坚强走过来的力量和帮助。最后，我想对各位病友说，我们无法选择疾病，但我们可以选择面对疾病的态度。越坚强，越积极面对，希望就越大。患上癌症不一定是生命的终点或者是绝望，我们可以用不同的角度去扭转对生命的认知和思考，生活依旧美好。经历过病痛，反而更能体会人生的幸福。我们还可以创造不同的理想和愿望。虽然我们的生命转了个弯，但我们也能生活得更精彩。各位病友，我们一起加油。
Thank you very much, Jiang, for the heartfelt sharing session. We hope the story gives emotional support and comfort, especially for those who are experiencing similar health conditions. We move now to the question and answer session. Thank you very much for putting these questions in. I'm going to rotate the people who answer this. Can I pass this to the first question to Dr. Fu, please? Is chronic constipation associated with or lead to diverticular disease, colon cancer, or rectal cancer?
Thanks, Emil. So in short, actually, absolutely no. Chronic constipation definitely does not lead to colon cancer or rectal cancer. However, colon and rectal cancers can present with constipation. However, this is usually a new onset constipation, meaning it's not a constipation that a person has experienced for 10 years, 20 years. It's a sudden change in your bowel movement where perhaps the bowel movements have been once or twice a day, and then suddenly for a couple of months, 3-4 days, the person is not passing motion, and then followed by maybe diarrhea. So a sudden change or a sudden constipation can signify something wrong. Chronic constipation is related to diverticular disease, but it's a bit difficult to tell because it's a bit of a chicken and egg. We know that there is a correlation between constipation and diverticular disease, but we don't really know which came first.
Rob, you're muted.
Yes. Sorry, thank you very much. The next question to Dr. Kaur, can benign tumors become malignant?
Hey, hi. Yeah, I think what this question is asking probably is can a benign tumor or polyps become cancerous? The answer is yes, which is why, as what it was alluded in Dr. Isaac Sell's last few slides, the whole idea of us trying to remove all these benign tumors or polyp in the colon through colonoscopy is one of the aim to prevent them from having a chance of turning into cancer. So yes, tumors, although they are benign, they contain the potential of growing into cancer if they are left alone for long enough.
Okay, thank you. So don't leave it too long is the answer. The next question is to Dr. Xiao. If a FIT test is negative, can a patient still request for colonoscopy via polyclinic referral?
Yes, certainly. If FIT test is negative, if the patient has slightly higher risk factors, including family history of colon cancer, family history of polyps, or is above 50 years old and is appropriate age for screening, you can definitely speak to your polyclinic doctor or GP to request for colonoscopy.
Thanks. Actually, because it was such a short question, I'll ask you the next one again. Can a person with end-stage cancer with chemo 2 years do rectal surgery? I suspect there's more to it than that. Maybe you can embellish the answer a little bit.
Yes, it sounds like quite a complex case of rectal cancer. Perhaps chemo is done in certain cases of locally advanced cancer, or sometimes is done to shrink cancer before surgery. So I would say that in certain instances, yes, for sure, surgery can be done, even curative surgery can be done after chemotherapy or after radiotherapy. But I think for this particular case, it is better to speak directly with the specialist in charge of the condition, because it sounds like this person is asking about a specific case.
Yes, thank you. There's certainly all hope is not lost, but everything is on a case-by-case basis when it's more advanced. I'll answer the next question, which is if using robotic surgery, if the robot is cutting and if the surgeon saw the robot went wrong, the answer to that is that the robot doesn't do anything wrong. It's actually still the surgeon. So the robot is actually directly under the control in real time. If the robot is cutting wrong, it's basically the surgeon cutting wrong. Okay, so you can stop. Usually what happens in extremely rare circumstances, you mean a malfunction, the robot can be undocked and be taken off, and then the surgery just proceeds in a normal laparoscopic manner again. But essentially, the robot doesn't do anything unless the surgeon commands it to. So it's very, very safe. Don't think the robot is doing a surgery. You don't have to worry. It's not the Terminator. It is still the human doing the operation. Okay. The next question is for Dr. Fu. Can pelvic pain, discomfort be symptoms of rectal cancer?
Yes, certainly lower abdominal pain or lower tummy pain and pelvic pain can be symptoms of rectal cancer, but usually this would be an instance of a very advanced, what we call locally advanced rectal cancer, which has been there for quite some time. Most commonly, rectal cancers first present with bleeding, as Dr. Kaur mentioned, but they can also present with, the medical term is tenesmus. Tenesmus is actually a feeling of pain and a constant feeling of pain inside the anus and rectum region, with a constant feeling of wanting to pass motion, but no motion coming out or no stools coming out. So that is a very dangerous symptom, which definitely should seek medical attention for.
Okay, thank you. Next question is to Dr. Kaur. The question is, FIT or stool blood test result does not always show positive if it's small, benign, or early stage cancer. Is this correct?
Hi, yeah, actually, it's not correct, because the sensitivity or the ability of the FIT stool tests are so good nowadays that they could detect very, very small polyps even. So yeah, so I think to answer this question, it would be that FIT tests would detect small polyps, even though it can be small. But I think the understanding should be then, it doesn't really mean that FIT diagnose you with anything. It's just a tool for us to, if it is positive, it should then bring you to the next step of investigations, which is colonoscopy, which will then help you to pick up those polyps or other lesions or inflammations in the bowel, which can also give rise to FIT positive.
Yes, thanks, Dr. Kaur. That's absolutely correct. I think the FIT test is in many ways like a conversation starter. So it doesn't preclude all the other symptoms that you may have. That's why you see a doctor with a FIT positive test, because they still want to talk to you about all your other symptoms. And just because it's positive doesn't mean you have cancer. Just because it's negative doesn't mean nothing is going on. But the FIT test is particularly good at picking up cancer. But for small polyps, the sensitivity does drop to about 70 to 80%. The next question is to Dr. Xiao. It said that there's a risk of rectal and bladder cancer for patients undergoing radiation for prostate cancer. Do you have any knowledge of the statistics for such occurrences and management strategies?
Oh, this is okay. Well, there is a risk of cancer with previous radiation, but this risk is extremely low and only a specific type of cancer called angiosarcoma. I'm not aware of the chance of this happening in SGH. All I can say is that we see this very, very, very infrequently. And furthermore, so because the current regime or technique of delivering radiotherapy is very focused on the cancer. So, you know, it doesn't affect the surrounding tissue so much anymore, and the risk is much lower these days. Thank you.
Thanks, Dr. Xiao. Next question is to Dr. Fu. Is the health screening tumor marker able to detect this? They've not been specific. I assume this is health tumor screening in general.
Yeah, so there is a tumor marker that doctors, that colorectal doctors tend to use. It's called a CEA, or carcinoembryonic antigen. Patients who have got colon and rectal cancer before and have had surgery before, they will be very familiar with this CEA, because every time we see these patients in the clinic, we will ask them to do this blood test called a CEA level. So that CEA level is what we call a tumor marker. But the caveat is this is actually not used for screening, meaning that we don't randomly use this. That means do a blood test like this on everybody. And if it is high, we pick these patients out and bring them for colonoscopy. So it's not meant to be used as a screening, but it's actually meant to follow up patients who have had cancer surgery before, or who have cancer and have had treatment for the cancer. The reason is this tumor marker called CEA is not specific, meaning that if it is high, it doesn't mean that you have colorectal cancer. You could have a lung problem, you could have a pancreatic cancer. There can be many other problems that can cause CEA to be raised. And conversely, if the CEA level is low, it doesn't mean that you don't have a colon cancer either. So it's a false reassurance. So the long and short to this is, if you're trying to go for some form of screening test, go for the FIT test. Do not go for a CEA tumor marker test.
Thank you, Dr. Fu. I think, would you like to answer the next question as well? How do I know which type of surgery is suitable for me, laparoscopic or robotic?
All right, so clearly this is a very technical question, and it has to be assessed by the surgeon who is seeing the patient, because everybody's cancer is different in terms of the size, the location of the cancer, the patient's body habitus, the type of surgery that patient has gone through before. So every patient is different. Generally, most patients who are suitable for laparoscopic surgery be suitable for robotic surgery and vice versa. However, there are just some small technical differences which may preclude one versus the other. It's not the same though for local excision versus complete excision of the rectum, because there are many tumors or cancers that cannot be removed via local excision and require a complete excision of the rectum instead.
Okay, thanks for that. Maybe I'll add on to that. The laparoscopic surgery and robotic surgery are not available for everybody. That's I think to be remembered. But robotic surgery in particular in Singapore is actually slightly more controlled, in that the funding from MOH and the recommendations worldwide in terms of the evidence are really for its use in confined spaces. So robotic surgery is particularly useful in the pelvis. But outside of the pelvis, in other words, for colonic cancer, tends to be less effective. still effective, but there are alternatives that can be used. So important to have a good discussion with your consultant when making your mind up. The next question is to Dr. Kaur. What are the causes the causes of colorectal cancer?
Okay. I think maybe the question is asking, are there anything that you can avoid in terms of food in your diet that could prevent the cancer? Well, I mean, anything that is well known, such as smoking and alcohol, are something that are well recognized that they are cancer causing. Recent years, there has been more association found between high consumption of red meat, particularly beef, that has been shown to have higher risk of getting colorectal cancer. Otherwise, actually, it's when it comes to food, it's very multifactorial, and more importantly, it's the amount that you consume. So long as you take things in moderation, it shouldn't actually contribute to cancer, and you shouldn't, because of fear of getting cancer, that you restrict yourselves to only certain kind of food, because then it will then lead to other problems such as nutritional deficiency, which is far worse. So my answer to this is that no, there aren't actually any single food type that can contribute to cancer. So long as you take things in moderation, it should be fine.
Thank you very much. The next question is, after successful rectal cancer recovery, that can't be quite right. Colonoscopy discovered more polyps, I would suppose. I think the question here that I'll pass this to Dr. Xiao. Patient has had rectal cancer before, has recovered fully. What sort of, beyond the original surveillance period, how often do you recommend a colonoscopy?
Yes, thank you for the question. I answered this actually in another question of similar nature in the Q&A. If a polyp is found on colonoscopy, we generally may recommend a subsequent colonoscopy earlier than 5-10 years. But this depends on the number, the size, and the type of polyp found. Because if you have one polyp, a small one less than 1 cm, it may be 3 to 5 years later. But if you have many polyps, of which some of them are 1 and 1 cm, and they are the kind that may be precancerous, it may be much earlier, even 6 to 12 months later. So it really depends on the individual basis.
Okay, thank you very much. Next question. Okay, this one is this one I would say everyone you see here, but really the Department of Colorectal Surgery here is a highly specialized department, and I think everyone is fully trained to manage this. So maybe get your polyclinic to refer in or walk in if you know who you want to see personally. Okay, move to the next question, please. Okay, this question back to Dr. Fu again. My husband had a hemorrhoidectomy done in 2016. On and off, he still has bleeding. Should he go for colonoscopy to ensure he does not have cancer?
Yes, absolutely. Because number one, we need to ask your husband if he had done a colonoscopy even before his hemorrhoidectomy. Because very often in our practice, we always tell our patients, I know you are bleeding and it's most likely from the hemorrhoids, but I would prefer for you to go for a colonoscopy to exclude anything major inside the colon or the rectum before I remove the hemorrhoids, which is a benign condition. If your husband had not done a colonoscopy before the hemorrhoidectomy, he certainly should go for a colonoscopy if his symptoms are still persistent.
Okay, thanks very much. We have time for just one last question. So this is actually quite a common complaint. Back to Dr. Kaur again. If right colon in colonoscopy shows poor bowel preparation, when should colonoscopy be done again? And what are tips to better prepare for colonoscopy?
Hi, yeah. Okay, so well, the tips to better prepare for the colonoscopy would be to follow strictly to the diet restriction. a lot of the time, that is the main problem when it comes to colonoscopy. And in general, when you come to SGH for colonoscopy, we will require you to take at least 3 days of low residue diet and have a bowel prep on the day before colonoscopy. So long as you follow that strictly, most of the time you will then have adequate bowel prep. For patients that still have poor bowel preparations, generally we would advise that you should repeat a colonoscopy within 6 months to a year. If the bowel prep is really poor, for example, you have less than 50-60% of the lining is being seen or evaluated during the colonoscopy this time.
Thanks very much. Do we have any more time? Okay, I think we've run out of time, in fact. Okay, so thank you very much to everyone, and thank you for being part of our webinar today. We hope you've learned something. I believe there'll be a feedback form flashing up very shortly. And please remember to get yourselves screened and look after yourselves. Thanks from all of us, and goodbye and have a very good morning.